I'd like to welcome everyone to our series of Buncke Clinic Virtual Visiting Professor Lectures. I am Bob Aksafa, and along with my partners, Drs. Greg Buncke, Rudy Buntic, Andrew Watt, and Walter Alain, I'd like to welcome everyone from around the world. This morning, we have the distinct honor and pleasure to introduce a true icon in the field of brachial plexus surgery, Professor Alain Gilbert from Paris, France. Professor Gilbert really needs no introduction in this field. There are just a couple of highlights that I'm going to hit. He was a past president of the French Society for Surgery of the Hand, past president of the European Federation for Societies for Surgery of the Hand. He was a former chief of hand at the Faculty of Medicine at Paris. He's been performing brachial plexus surgery since 1977, so an incredible experience. And together with his current partner, Dr. Piero Raimondi, he has repaired over 3,000 brachial plexus lesions. I mean, these numbers are astronomical, and I think this is why he is truly one of the global thought leaders in the field of both adult and pediatric plexus surgery. Last year, many of you have seen me show slides of a very amazing symposium that Professor Gilbert put on in Paris, and this was a peripheral nerve reconstruction symposium that was titled News and Fake News, trying to look at the data in all aspects of nerve surgery and trying to dispel some of the myths and looking at the exact science. And this was really a meeting where thought leaders from all over the world were able to come in and share their experience. In fact, many of the speakers that you've already heard in our series over this last month, Dr. Rod Hentz, Professor Sabapathy, Dr. Bertelli, Dr. Jonathan Isaacs from VCU, Dr. Amy Moore from Ohio State were all there, and they've given us talks just the past 2 or 3 weeks alone. So there's a lot of commonality there, and I want to thank Professor Gilbert for hosting this symposium. Many of us who know Professor Gilbert know him for not only basically being a global thought leader, but also being a champion of global surgery. And Professor Gilbert travels throughout the world regularly and has not slowed down at all to perform brachial plexus surgery on children. Here he is operating in Chile, operating on a child with a brachial plexus lesion. Really tireless work. He travels. Here's a picture of him in Kuala Lumpur in clinic. You can see with many, many visitors trying to learn from the master himself. And here he is operating in Kuala Lumpur as well. He travels to Morocco regularly, operates there. So truly a surgeon who believes in not only operating locally where he is, but also global surgery and teaching local surgeons as well. With that, Professor Gilbert, I'd like to thank you again for joining us. It's really an honor and a pleasure to have you today. And we're really looking forward to learning from you. And I'm going to give you control of the screen so that we can launch your slides. Thanks again for being with us. All right, there you are. And you should see a prompt in just a second to share your screen with us. Perfect.
Okay.
And I'm going to ask everyone to please keep your microphones off and your webcams off until the end of the talk for questions. Thank you so much.
Thank you, Bobak. First, about what you said, one is not such a nice compliment. It's that I've been starting this surgery in 1977. That means 43 years of brachial plexus surgery. I'm quite old now. So, and the second thing is, I agree with you that the meeting last year in Paris was absolutely excellent because so many good people were there. And while we have here Orlando, please ask him to send you, if you don't have it, all the presentations of this meeting that he's supposed to have them, and I'm sure he will be happy to send you all these presentations.
Great, now, I will. Thank you so much.
Okay, now we're talking about obstetrical brachial plexus. I'm not going to to have a whole thing on it, but I want to really focus on diagnosis and indication, because this has been something which has been, I would say, recently updated or refined, and we will see how. First, of course, the diagnosis is very important. It's important because, I'm sorry, I'm trying to,
If you're looking at the control panel up top, we actually don't see that, so you should be okay.
It doesn't matter. Okay, so we see that this is the usual appearance of a upper plexus. You know, you just by looking at it, you have usually you can make a diagnosis, and of course the complete palsy is also very evident with a flail arm and Horner syndrome. But we want to stop a little on the Horner syndrome because, of course, we have the idea that Horner syndrome means avulsion of T1, and very often it is the case, but not always. And we have cases, this is a patient you can see who has, you will see him a little better, has a very severe Horner syndrome, you see, and the paralysis of the right arm. But you see a normal hand. So it is possible to also have this. And on the opposite, this is a patient who has absolutely no Horner and a complete paralysis of the hand. So Horner syndrome is important, but it's not pathognomonic. Now, another question is, do congenital brachial plexus exist? It's very important. It's important, especially for low problems, because you know that sometimes the defendants say that it was not their fault because it was congenital. And in fact, it does happen. And this is a patient, for instance, who had, as you can see, anomalies, congenital anomalies with absence of the thumb and associated with a complete paralysis. And operating on the plexus, we can see that there is no plexus. It is replaced by fibrous tissue. And I have seen these only in 3 cases out of 6,000. So it's a very rare occurrence, but it does exist. Now, when we have a paralysis, of course, you have to look at associated or differential diagnosis, like fracture of the humerus, which heals very quickly, usually in 3 weeks, it's finished, and fracture of the clavicle. Fracture of the clavicle is very often part of the paralysis, because you know that the obstetrician break the clavicle in order to diminish the biacromial diameter. Now, the metaphyseal fracture is close to the shoulder, and it very often mimics paralysis. But again, after a few weeks, it will heal and there will be a complete recovery. More difficult is the upper epiphysiolysis. This is extremely rare also, and I don't think it would be really often one-off problem for you. We have to remember, for instance, that shoulder dislocation, neonatal shoulder dislocation exists. I have seen 4 cases in the past 40 years, not very common, but one thing is that it cannot be reduced. It has to be operated. There is no possibility of orthopedic reduction. Now, when you have this patient, you have to go in details about examining the patient. It's very difficult to examine muscles, very fine muscles in small babies. So you examine usually functions. And in the upper plexus, you cannot examine separately, or very difficult to examine deltoid, external rotators. Only the biceps can be studied, and we'll see again. In the wrist and hand, you can examine wrist extension and finger flexion. Why do we specially examine the biceps? First, because it's pure upper roots, and two, because it can be studied individually, and that's very important. And what is important is how to study the biceps. And the biceps is not elbow flexion. So that's something you must keep out of your mind, is that when you say a patient has recovered elbow flexion, it means absolutely nothing, because it can be recovered with brachioradialis. So examining the flexion, you see the position, you have to put your fingers on the biceps, and when the child flexes, you need to feel the contraction of the biceps, because you can have the same flexion without any biceps. Now, wrist extension is very important, not for diagnosis, and we'll see why, but to determine the technique of repair. And this is it is very important to determine the extent of the lesion, because especially in the hand, you must remember that you may discuss the recovery of the shoulder, wait to see what happens, maybe partial recovery, but in the hand, a persisting defect leads immediately to surgery. There is no way that it can recover by itself if it's after a certain time. And it is very important to evaluate the extent, because you have to decide, of course, the exploration and the timing, and you have to prepare also the family. You have to tell them in advance if you are going or not to do a clavicular osteotomy, a contralateral C7 transfer, where you are going to harvest the grafts. So you have to know what you are going to do before the operation. I don't think that you should make this big decision. You make, of course, the decision of operating. You can have the strategy during the operation, but it will not change much because of the operation. Then, especially the hand is sometimes difficult, because you may have partial impairment. That means that you will need to explore the lower roots separately, see them, stimulate them, and not believe that they are a hole. You can have very often C8 avulsed with a T1 in place. This is quite common, or partial T1. And then we have the problem of C7. You have read everywhere that C7 will give wrist extension and so on. But this is a slide from Barrero, and he shows very well this case. You see, this is a case where the patient had no extension of the wrist, and at exploration, there was a normal C7. So at that time, extension of the wrist was coming only from 5 and 6. Another case where there is a normal wrist extension with a lesion of 5, 6, and 7. That means in that case, extension of the wrist was coming from 81. So we cannot say exactly what means extension of the wrist compared to C7. So do not make decisions on the level before you have operated. Again, we have seen that the examination is not easy in a small baby, so that's why we examine functions. And of course, everybody knows the mallet shoulder scale, which was published a very long time ago, almost 50 years ago. And but it can be used only in older children. You should never use that in a small baby or in 1 year old. You need 4 or 5 years old to be able to, that the child understands what you want. In 1977, beginning, Tassin was working with me, and he made his thesis on the spontaneous recovery according to the age of biceps recovery. And this was the base of my indications since now 40 years. If the biceps recovered before 1 month, then the shoulder will be grade 5, normal. If it recovered between 1 and 3 months, the grade 4, which is reasonably good. and after 3 months, grade 3, which means insufficient. So in complete paralysis, we have often a partial proximal recovery. And after 5 or 6 months, when the family sees that they have recovered some elbow flexion or some abduction, they don't want anymore to do surgery because they believe that the rest will follow. But that's why it's important not to wait and do the surgery early, especially in these complete paralysis. Then we have two main controversies. One is whether the obstetrical plexus should be operated, and the other is when should the decision taken. Should it be operated? And of course, we still have a lot of discussions, and because when we talk about good recovery, we don't talk of the same thing. If we are a neurologist, if we are a physiotherapist, if we are a surgeon, or if we are a patient, we don't believe the same thing. A patient, we will have a lack of abduction, but a very good hand. A neurologist will say he has a perfect result. A patient may not feel the same thing. So this is something which is not easy to standardize. I use, for me, as you have seen, the biceps recovery to make my decisions. And there are other scales, and one of them is that I think many of you know is the Toronto active movement scale, for which I have a little. There is a problem for me. The problem is that you see, there is elbow flexion is measured, and we have seen from the beginning that elbow flexion doesn't have significance, and we cannot say because we have a recovery of elbow flexion that the upper roots have recovered. So this is something, that's why I prefer the biceps recovery. Now, there have been several very large studies from Gilbert, from Wahl, from Grossman, who had shown spontaneous recovery in these patients. And there was a very good paper which was done by Pondag from Holland in 2004, where he did a review of the literature, and he found that first, spontaneous recovery, the result of spontaneous recovery is notably worse than it is suggested. And two, that we should be very cautious in predicting excellent recovery after birth because we don't know what will happen. So I really, you should read this paper, which is excellent, from Pondag. Now, when should it be done? For many surgeons, 3 months. For others, 6-9 months, and some others, it depends on the variation of their assessment scale. So there are really variation. But one thing is we have to understand that when we speak of repair, we speak of actual surgery, because the decision is taken, and very often you have to wait a few weeks or sometimes a month before you can do this surgery in the hospital schedule. So the question is there a difference in result before an operation at 3 months or 6 months? Probably not. And in my experience, there's been no difference. The bigger problem is whether you are more precise at 3 months or at 6 months. And I am not sure. And it has not been proven that it is better to wait 6 months instead of 3. And then we have a very serious argument, which is the psychological. And the more signs of recovery for the end result, the more difficult it is for the family to take the decision. And very often they will drop out because they see some recovery and they will find a physiotherapist or somebody saying that, oh, it's coming back, don't do anything. That's why the choice is between an early operation, with the risk of an excessive indication, or a decision which would induce some refusal by families. My choice has been to do the early surgery, as we know that surgery allows better recovery than spontaneous recovery. Now, finally, the indications. Upper palsy, you see no biceps at 3 months, to be precise, because we will go in details. And complete palsy, of course, is Horner syndrome and no hand function at 3 months. This was my series of obstetrical palsies. On the side, just to note one thing, of course, there is a difference, right, left, but doesn't make much difference. But what's important is to know that there are some bilateral cases, and these bilateral cases are almost always breech deliveries, and they are very severe cases, usually avulsion injuries. And so when you see a bilateral case, it's a very difficult thing to repair because we have not enough grafts because they are avulsions. The pre-op studies, EMG will be good for maybe to precise diagnosis, but not for prognosis. You should never believe when it says on the EMG that the patient is recovering. CT, MRI, for many years I said that it was not necessary, but I will show you that now I came back and I'm feeling that we should do more of MRI. This was the time of the myelogram. We don't do anymore, but there was a lot of false positive, false negatives. Myeloscan was better, but you know, it was also, you need to inject, and it was sometimes a problem for the babies. So MRI has come, and of course not always dependable, but now getting much better, especially in babies, because it was always quite good in adults, but in babies it's not always precise. But what I wanted to show you is this, is another series of myelograph which I did, and I had 4 failures. These failures, I went back and took out the graft, and the result was this, of one case, for instance. And we see that in that case, for instance, there was nothing in the proximal nerve stump. So that means that the failure was due to a mistake that I did of grafting a non-viable root. And that means after thousands of patients, you see that you can still make this kind of mistake. That's why I think that using MRI is very important. And you can see I did a post-op MRI to one of these patients, and you can see that we find complete avulsion of the roots after that case. So that's why I really think now that especially in upper root cases, I would do a MRI. Now, intraoperative decisions, of course, you need experience, and that's clear. Let's come to details. Now, you first for the flail, shoulder, and elbow. That means upper brachial plexus avulsion. In that case, I would do a double fascicular transfer for elbow function. You know, the 2 transfers. This is it, and gives good results. A double nerve transfer for shoulder abduction, you know, spinal accessory to suprascapular, and triceps to axillary. This is it. And this is a result. And you can see that even though these patients have a beautiful result, they still have a shortening of the arm. And that is a problem we have not been able to solve. So the 2 questions is why, in this case, I would use a double transfer for biceps and not in another case. And you see, the reason is that if you have a neuroma, you may have a chance of recovery of the biceps or the brachialis. Then if you do a single transfer, you can add the chance of going through the neuroma and the transfer. If the two roots are avulsed, then there is no other chance. Then you should do 2 nerve transfers. Same with the deltoid. We have the same problem. You know that when we repair with nerve transfers, we used to repair with nerve transfers some patients who had neuroma in continuity, then about a large part of them will recover spontaneously a part of the deltoid. But then, of course, when you have an avulsion, you don't have this possibility. But if you do not repair in an avulsion injury the deltoid, then you may have an excellent result immediately, but 8-10 years later, the arm will be heavy, and the patient, the child, will lose abduction. So in these cases, I will do also reconstruction of the deltoid. Now, if you have a rupture of the upper roots and no wrist extension, then my recommendation will be to use a graft from the upper roots. And I think it is better than nerve transfers because especially the problem of the wrist extension. And we will talk about that problem of wrist extension because that's a real problem. This is a patient here who had a graft, C5, C6 graft. Why? At the moment, I still prefer to use a graft than distal nerve transfers to extension. And for me, there are 2 reasons. One is a risk of making secondary tendon transfer more difficult, depending on the distal nerve you will take. Some of these distal nerve transfer will preclude any transfer. And then the second is to have the reliability, to see the reliability of the procedure. And all we have seen are very small series. We don't have at the moment some large series showing really the reliability of this distal nerve transfers. Now, so on the opposite, when we have upper root rupture with wrist extension, then the problem is not the same. Then we can do the triple nerve transfer, biceps, external rotation, deltoid. 1 biceps, of course, reconstruction. And then in this case, we don't have the problem of extension. But in that case, again, we are not in a hurry, and we can wait 1-2 months if we have a doubt, because we know that the nerve transfer can be done later. So what we can say is that isolated neurotizations give excellent results. When a graft is good, the result is close to perfect, but, and we will see that, association of a graft and nerve transfer decreases, in some cases, the result. And this is, for instance, study of my cases of 100 children with suprascapular nerve reconstruction. You see that what's very interesting, when you look in red and in red are the upper lesion, in yellow, the complete lesions. And you see that the same operations give different results. That means that in complete lesions, we have not so good results. And again, in upper lesions, usually these are cases where we do only nerve transfers. In complete lesions, it's an association of grafts and nerve transfers. In complete paralysis, of course, there is of course, we need always grafts and or intraplexal nerve transfers. And of course, these are the typical situations. What we must remember is about the quality of the roots, because we talk about number of roots, we talk about where they are, length of graft, but we forget the main problem, which is the quality of the roots. And unfortunately, we are not able at the time to really assess rapidly and safely the quality of the roots. And of course, in the very complete avulsions with 4 avulsions like here, we will associate grafts with nerve transfers and contralateral C7. That's why there is, for me, an indication for primary use of contralateral C7 if there is 4 or 5 root avulsed. But that's, you need, of course, to have 4 or 5 roots avulsed. You need to have prepared the family, discussed with them. They have accepted. Preparation of the child at the time of the operation is very different. So it's a bit complicated when you think that you may need a contralateral C7. This is a patient, for instance, who had this avulsion. Another question is, how late can we repair that plexus? And what we know from the literature, not from my experience because I never did late grafting, but from the literature, there are not many papers, they show that there is no good results after 12 or 18 months. But nerve transfers are possible. And this is a patient, for instance, I did that many, many years ago, and that, triggered me into thinking. This is a patient, you see, he was already 9 years old. He had no elbow flexion. And in that case, I did a secondary nerve grafting from C5 to the biceps, and he recovered biceps after 9 years. So we did a series with Piero Raimondi, and we did 93 late nerve transfers, and 22 of them were in obstetrical paralysis. And these are the cases. These are elbow flexors. You see the results in late we considered was over 1 year and up to several years. And these are the results. And you see that a very large majority of these patients had an excellent result over M3. Even in external rotation, the results are not so good, but still quite good. You see that in the bicep reconstruction in our series, we had 85% of excellent result after more than 1 year, and in external rotation, 50% only. Now, this is, of course, this is one case who was operated at 18 months, and this is the result after 6 years. Another girl operated at 2 years after 7 years. Now, then we looked into details. So how long, was there a difference according to the time elapsed? So we see in these cases that the excellent M4, where of course almost all of the patients between 12 and 18 months had excellent. Between 12, 18 and 24 months, half of them. And again, after more than 2 years, we still had a large majority of patients who had M4. So that means that this late surgery can be done very late. When we have a complete brachial plexus, like you see, this patient, many of these patients have spontaneous recovery. They were not operated. They have spontaneous recovery with a 0 hand and sometimes quite good proximal recovery. So in this case, we can do, of course, sometimes the nerve transfer with the brachialis nerve. Either directly or using a graft. This is another patient here, absolutely nothing in the hand. And here we are. See, nuts. It is something which is not easy to control by the patient. And you see, suddenly she finds the trigger. So it can be used either for the flexors or even on the radial nerve. And this is a patient who had the transfer for the extension. And you see that he recovered extension of the wrist. But this is a very limited technique, you see, because the big problem is that if the patient has no wrist extension, it doesn't work well for flexion. So you need, it's on very limited cases that you can use that. If you have no hand, no elbow, no shoulder, but you still have fibrillation, which means the muscles are still alive, that is the case where we can use a late contralateral C7 using the, this is the Wang technique. In fact, the Wang technique goes behind the esophagus. I have done that a few times, but there's no use because in babies, even if you go behind the esophagus, I have never been able to do a direct suture. So I'd rather go in front, which is much quicker, and do a graft. This is the type of patient we see that will need this, and this is the graft. And instead of using a graft, my preference have been to use allograft because putting a graft in the neck is not easy, and especially to get a good congruence. I did 42 patients with allograft in 2 years, and these are the ages. You see, the very young ones are primary surgery, and the older ones are failures or secondary surgery. And what you see that we have, I have used them essentially for different type of repairs, but 7 of them were done in contralateral C7. This is the type of repair that we will do. And this is a patient, 18 months. We had a complete paralysis, not an obstetrical, but traumatic. And this is after 1 year. You see nothing. The hand is completely plain. 1 year after the contralateral C7. And here we are after 2 years. You see that it's starting quite well now. Again, another patient, 11 months. And this is after 1 year. So it is sure that this Contralateral C7 can be very useful in these very terrible cases. So these are the conclusions I wanted to give you. First, in severe OBP, the surgical treatment is superior to spontaneous recovery. I say that, but there are still people thinking that, or saying that we should wait. Second, a very good clinical initial assessment is absolutely necessary to make a reasonable indication. Three, the nerve transfers are useful, but cannot be the unique treatment proposition. There are many situations where the graft gives a better solution. Delayed nerve transfer can give good results even after several years. In adults, I have patients after 7 years who have nerve transfers gave good results. And in very severe multiple avulsion, the contralateral C7 technique may be used. In these cases, the allografts are very helpful. Thank you.
Great. Thank you so much, Professor Gilbert, for another fantastic talk. Every time I hear one of your talks, I definitely learn quite a bit. So thank you so much for that. We do have a number of questions that were posted in the chat box. I'll try to get through many of them. I think the first one is a more of a not a technical question, but as you mentioned, early treatment is best, as with many nerve injuries, be it peripheral or plexus lesions. What has been your experience in trying to educate people to refer these patients early to you? Because I think when you have a problem that is relatively widespread, and especially in parts of the world that may not have access or may not have the knowledge to make these referrals, what is the best way to get the word out, and how have you done that?
Let me tell you the history. I started in 1977, and after maybe 6 months, I had very few cases, but some absolutely terrible pictures of neuroma, ruptures, avulsions. I went to the National Association of Obstetricians, and I gave a talk. And the people they would not understand, because they didn't think that this would happen. Then they started to send a lot of patients. I was alone, and I used to see maybe, I would say, 80% of all the patients in the country. And this happened for more than 20 years. And then slowly, there was a change. One is too many people started doing it everywhere. Yeah. Then second thing is there is now a kind of a idea that you see everywhere on the social networks, on the, I would say, soft medicine, natural medicine. You should not touch, you should wait, you should take plants and things like this. And this has decreased a lot. And you know that there's still the same number of patients in France now every year, which is about, I would say, 200 or 250 to be operated. And the number of operated patients is divided by 3.
I see. And I think one of the problems probably is that these are very specialized cases, and so many surgeons don't feel comfortable doing an adequate diagnosis and intervention, and that may have something to do with it.
Mm-hmm. Also, and the other thing is that these operations, when you are used to it, it's very quick. Normally, upper root graft was about 1 hour, but when even if you use an allograft in 35 minutes, you can do it. But The problem is that sometimes some people will take 5 years, and the hospitals don't feel comfortable, and the anesthesiologist, and then it becomes a big operation, and they are reluctant to accept it in some places.
Right. Now, speaking of allograft, you've obviously had a tremendous experience with allograft as far as numbers go. We use allograft a lot, but it's almost always in peripheral injuries and trauma type cases. And the question is always, the mechanism of recovery in an allograft, specifically with regards to the length. Obviously, we know that the allografts don't have Schwann cells, and so they need to have Schwann cells migrate from both ends to repopulate the graft. What has been your experience with regards to the length at which you're reaching a maximum recovery for the allograft? And what do you think the mechanism is in children? Because it seems like in adults, there's definitely going to be a limit to length at some point.
Well, I'm not sure that the length is the limitation, because I have no experience with peripheral nerves using allografts. But what I found is that, and I showed you some of it, that in the brachial plexus, the most important is the quality of the nerve. When you do peripheral nerve after a cut, you have good nerves. But in brachial plexus, many of the roots are fibrotic and lack of nerves. And then in these cases, the results may not be good. So I think the quality of the nerve, of the donor nerve, is absolutely the most important thing if you want to do. It's also the same for autograft, except that autografts are probably more tolerant. And if you don't have a good quality of donor nerve, you cannot have good results. This is absolutely clear.
And I think that's a fantastic point. And we found ourselves to be much more aggressive in the last 5-10 years with resecting the nerves back, especially with using allografts, to make sure we're outside the zone of injury. Looks like Professor Balakrishnan is on and he would like to ask a question. So I'm going to call on you, Professor. Thank you for joining us.
Alain,
yes.
My doubt is on the contralateral C7. When you use the we don't have the allografts. We always have the pleural grafts or take the forearm cutaneous nerve, arm cutaneous grafts. Now, do you have any experience or do you reckon that you should do the shortening of the humerus to get the primary closure of the contralateral C7 to the lower trunk of the affected side?
I'm sorry, I
cannot. Have you ever done shortening of the humerus to get the primary anastomosis of the lower trunk of the affected side to the contralateral C7?
I think the question is what do you think about shortening the humerus in order to achieve primary coaptation in a contralateral C7 transfer?
Yes, Wong is doing that. I have never done it, and I doubt that our patients would accept that. And I really prefer to do a graft than. I understand the idea because it is true that a direct suture is excellent. And in adults, I will always do a direct suture. But in babies, I'd rather do this graft.
Got it. A question, speaking of the adequate proximal nerve, there are a few groups that have described their experience with performing frozen sections proximally to ensure that they have they're outside of the scarred area. What are your thoughts on doing that, and have you ever done it?
All of these are very interesting, very promising, but at the time, there is no way to know quickly the answer. That means many cases you have to do it and then you get the result after the operation. And even if you want to wait, it takes sometimes an hour and a half. And we cannot wait for such a response. I'm sure we will be able to get a quick answer in the future.
Got it. Professor Balakrishnan, I think you had another question. Did you have a follow-up question to ask, Professor?
Alain, regarding the upper trunk lesion, which is identified by your MRI, only upper trunk, are we justified in operating after a year? Because the lower C7 and the lower trunk are intact. Only the upper trunk lesion. Are we justified in operating a year later for the child? Do you think that 3 months still holds good?
If you have only the upper trunk.
Yeah,
Yes.
only the upper trunk. Are we justified in operating late?
You see, the problem is I don't see it this way. If you see the patient early, you should operate early. If you see him at 1 year, you can still operate at 1 year. But you should not make the choice to operate at 1 year. You have seen that after more than 1 year, we have only 50% quality of results. So if you want the best quality, you need to operate early.
Great. Thank you, Professor. There are a couple of questions about your thoughts on the indications for a free functioning muscle transfer in obstetric brachial plexus palsy. Would you mind commenting on your indications for that?
You mean the rehabilitation or what?
No, just the indications for performing functional muscle transplants.
Well, there are two things. One is using it as a secondary surgery, you know, in patients who have lost a lot of things, and then I have done quite a lot of these. And the results of my free vascularized muscles are not extraordinarily good. They are about 60%. And then I have seen a few cases, a few presentations showing immediate use of free vascularized. And I am not too convinced, because you can do a very good muscle transfer, but you need a nerve. And when you do a repair, usually these surgeons, they do in the same time a nerve repair and the muscle transfer. You never know, of course, that the nerve repair will never give you 100%. This does not exist. So some of these cases we lose the muscle because the nerve will not recover. So I don't see really the interest of doing immediate muscle transfer. But maybe I'm too old.
No, I think it makes a lot of sense. I think you give the nerve a chance to work with a proper reconstruction, and if it doesn't work, then maybe you could do some transfers. Dr. Greg Buncke, I know you're online. Any comments for Professor Gilbert?
Yes, Alan, thank you. Can you hear me?
Yes, we can hear you.
Great.
Yes.
Alan, thank you so much for the talk. That was fantastic. And I want to just comment, number one is on your courage to have started doing this early on in the 70s and 80s, when everybody was really a naysayer against doing nerve grafting, and especially in kids. You were always committed to it and knew that it was a worthwhile thing to do. And I think we all appreciate that. The question I have for you is, in the contralateral C7, have you had much problems in the donor side, the essentially normal side, taking the C7? Have you seen any short-term or long-term problems in those patients?
First, let me tell you that it was easier 40 years ago than it is now, because there is no But if you try something like this now, you need to go to a lot of ethics committees and things like this. They will probably refuse anything. So anyway, but for the second thing, I have seen in adults, in children, in babies, I have never seen complication. But you see, it's very difficult with the babies to test them or anything. But when I ask the families or anything, they never. The family never says that that they've lost something. But anyway, but in adults, I have never seen paralysis. I've seen 2 cases of temporary paralysis, but very, very little. But I have a few cases, maybe 5 or 6, of tingling over the thumb and index, which does not disappear very quickly. I think that's what they complain.
Great, thank you.
Got it. Well, Professor Gilbert, I wanted to thank you again for taking the time to educate us. We had up to 85 viewers from all around the world at one point, and I want to welcome our guests from India and from other parts of the world, including Europe and Canada, who have joined us today. So I really want to thank you again for doing this, and it's good to see your face on screen, but it's not the same as seeing you in person. So I hope to see you soon in person as well.
Thank you. Goodbye.
And also one last thing, a housekeeping matter. I'm going to share my screen here for people. So we have just posted our existing videos online, and the way to access them, let me just go here full screen. If you go to my partner Rudy Buntick's educational website, microsurgeon.org, what you see on the top left with new, it says Virtual Visiting Professor Series. And if you click on the Virtual Visiting Professor Series, you'll be taken to an additional page. The direct link is microsurgeon.org/webinar list. And there is a calendar that you can import to include with your Google Calendar. There's also a schedule as a Google Sheet, and all the videos are posted online for you to access at any time, and it is free. Our next lecture is this afternoon Pacific time at 5 p.m. Dr. Jim Higgins will be discussing refinements in microsurgery in the upper limb. With that, Professor Gilbert, thank you so much again for joining us, and stay safe, and we'll hope to see you soon.
Bye-bye.
Thank you so much. Bye.